I'm going to be talking about particularly one aspect of the metabolic profile in diabetic women that troubles us most. All of us know that in general, whether it's a man or a woman with diabetes, most people die of cardiovascular disease. People with diabetes are 4 times more likely to die of a heart attack than their non-diabetic counterparts. But apart from that, what I'm going to show you is that there is a specific gender issue here where women are even more prone to that cardiac risk than diabetic men. And we need to pay special attention to that, make sure that we are even stricter with control of the risk factors and primary prevention. So the discussion points would be, are women with diabetes at greater risk and why so? And should we be treating them more aggressively for these risk factors? I'm not going to actually, this is there in my presentation, but we've had a lot of talk yesterday and day before on HRT, so I'm not really going to dwell on that much. And then what about the risk reduction strategies? Is there anything different that we do with respect to the aspirin, the statin, etc.? So coming to the first question, are women with diabetes at greater risk for cardiovascular disease, and if so, why? Now, several studies have demonstrated that diabetes greatly attenuates or may even reverse the protective effect of the female sex on the cardiovascular risk. All of us know that at least until the menopause, women are far more protected than men in terms of cardiovascular disease. But when you have diabetes, that protection is lost. There was a meta-analysis in the last 4 years back, and this meta-analysis showed that the relative risk of incident coronary heart disease was 44% greater in diabetic women than in diabetic men. So that is exactly what I was pointing at, that the risk is increased in diabetes in general, but far more so in diabetic women as compared to diabetic men. And if it's a diabetic postmenopausal woman, then she's 3 times more likely to develop coronary artery disease or stroke than non-diabetic women. So it's really important for us to focus on this particular issue. And a diabetic woman is 4 times more likely to die from myocardial infarction than a diabetic man. So it's not just getting an MI. The mortality statistics also show that it's much worse for women, and that's the need of the hour to prevent this kind of a thing from happening. So that's the importance of this talk. So why does this difference happen? What's the difference? Well, I mean, what is the reason for this sex difference? So there are a lot of postulated mechanisms for this particular thing. Maybe there is an increase in the prevalence of the classical CV risk factors, or maybe in the effects of these risk factors in diabetic women. And maybe there is less of a diabetes risk control, we don't know, and interference with the protective mechanisms in the vascular wall in women with diabetes. We don't really, these are just hypotheses, we don't really know which of these really operates. It is not entirely related to chronic hyperglycemia, and there were several other factors also which could be at play, such as dyslipidemia, hypertension, genetic factors, environment, and a low-grade systemic inflammation, endothelial damage, lifestyle behaviors. Many a times, behaviors are such that women tend to ignore their health. They may have lesser number of visits to their primary care physician or to their doctor, and hence may not be picked up in time. So these are psychosocial factors, and these factors could also contribute to the worst outcomes that we see in diabetic women. So these discrepancies which I talked about, these increase with age and with diabetes duration, exposing older women to this higher risk. So age adds to it in a big way. So that brings us to the point, given these statistics, given the fact that we are more prone, should we be adopting different methods, more aggressive methods to treat? Just to give you an example, if a woman has had gestational diabetes, it was demonstrated in a study that despite the diagnosis of normal glucose tolerance after delivery, which means to say perhaps the woman may never develop diabetes even after that index case of gestational diabetes, but still she will still be prone for all the cardiovascular risk factors that a diabetes confers upon that woman. So prior GDM women are characterized by persisting subtle glucose abnormalities which may not be picked up, for example, by what we do 6 weeks postpartum or 8 weeks postpartum when we check the woman and pronounce that she's non-diabetic, or maybe every year after that we do it. But there could be subtle glucose abnormalities and insulin resistance, decreased adiponectin, increased CRP, thus exposing them to an increased CVD risk. I would say that perhaps these kind of subtle glucose abnormalities may be picked up by continuous glucose monitoring. We don't know. They may be normal by the blood sugar test that we do that can come up afterwards, but maybe CGMS sometime could pick these things up. Thus, women with a history of GDM, even though they are normoglycemic later on, should be still regarded as high-risk group for development of overt diabetes and CVD, and special attention should be given to preventive measures among these females. As I said, I'm not going to go into the HRT part because it is difficult to predict the overall harm or benefit of HRT on CVS, and we don't really advocate giving HRT to prevent cardiac disease anymore, although there's a lot of controversy, and we've gone through that in the last few days. And if you look at all these studies, only the last study had a separate subset of diabetic women. All the other studies were all common, so I'm not going to delve into that because the effects of estrogen may vary a lot depending on the age, other risk factors, and the stage of the coronary artery disease. What about aspirins and statins? At this point of time, we do not have gender-specific guidelines for the usage of aspirin and statins in diabetic women. So all we can say is that we should be very vigilant. We should have a strict control of the risk factors, but we still do not have separate guidelines to tell us about aspirin and statin usage in diabetic women. So the guidelines as of now remain the same as it is for non-diabetic women and the general population. So to conclude, the incidence and the mortality of coronary artery disease in women increases after menopause. Loss of ovarian function, deficiency of endogenous estrogens added to age, abdominal obesity. That's a huge part. All of us know that women naturally have a higher fat percentage than men. This increases again after menopause. And added to that, a sedentary lifestyle, and in India, maybe an increased carbohydrate intake, putting on weight. All of it adds to it and promotes the atherosclerotic process. We've heard so much about inflammation, atherosclerosis in the last few days, and a fat percentage sarcopenia, which you heard this morning. So all of that may be adding to it. It's well established that estrogen has favorable effects, but we need large clinical trials before you can prescribe, before we have any outcomes to tell us that estrogen can help us. But basically, cardiovascular prevention requires correcting the lifestyle and other classical risk factors, particularly a very strict control of the diabetes, looking at all the psychosocial factors. We would always be looking at the figures, but the psychosocial factors may play a huge part in the management of diabetic women, especially so in India, where most women are dependent and may not even come to the doctor on their own, always accompanied, many a times accompanied by somebody. So we really need to take care of that. And this talk was meant to get your attention to the fact that cardiovascular disease is a huge problem, especially in women. So we can take some of the questions during the panel discussion. So I conclude here. Thank you all very much.